Greetings, I'm Dr. Kim Kyung-won of Online Surgery. I'm honored to meet you via surgical video. Let's look at today's surgery. The patient is 64-year-old male patient. This is panoramic image at initial visit. The patient's medical history. The patient is slightly diabetic and the patient was taking oral medication and comparatively it was well controlled. Approximately 10 years ago, bridge was done in number 25 and 26. In number 25, there was secondary caries and there was an issue. The prosthesis has been removed. In number 26, prosthesis was to be refabricated. There's root rest in number 25 and therefore immediate implant placement after extraction was planned. Immediate implant placement after extraction was planned. Before surgery, CT was taken to check number 25. The root is divided into two. The buccal-palatal root is quite long and thick. After extraction, as shown, compared with implanted diameter, there's going to be a much bigger space buccal-palatally, over 10 millimeters. If you look at the CT on the palatal root, there has been endodontic treatment, and on buccal root, there was also endodontic treatment. In the case of immediate implant placement in premolar area, in order to get primary stability of the implant, you need to get it from the apex side, but the root tip is almost in contact with the sinus floor. As I drill, I'm going to penetrate the sinus floor intentionally, a little bit. I want to get primary stability from the sinus floor. Because it is upper premolar, I'm going to place the implant slightly palatally. In that case, there's going to be quite a significant gap in the buccal side, and I anticipate that there will be a need for a bone graft there. KS3 4.5 implant will be placed. The length is going to be 10 millimeter. In this case, final drill, I'm going to penetrate the sinus floor. Therefore, I'm going to drill up to 4.0 or 4.5, assuming that this is a normal bone. Root is going to be extracted, implant is going to be placed like this. Sinus floor is going to be slightly intentionally penetrated to get primary stability. If you look at the post-op image, implant has been placed in the intended area and sinus floor is slightly penetrated. This is post-op CT image. As mentioned earlier, implant itself has been placed slightly palatally and primary stability has been gained by slightly penetrating the sinus floor. Because implant was placed palatally, the gap with the buccal cortical bone was over 3-4 millimeter and therefore allograft material was used for bone graft. Gap filling was done because immediate implant placement was done. Primary closure could not be gained. In areas where graft material were exposed, the collagen membrane was used for coverage. Hidden X suture was done to fix the membrane. Collagen membrane was used, and a type of open membrane technique was used to complete the surgery. This is post-op image. If you look at the panoramic image, it is premolar area and it looks slightly slanted. However, on CT, the path looks okay and implant has been placed nicely. Let's look at the surgical clip. Because endodontic treatment was done to the tooth, atraumatic extraction is very important. Multiperiosteal elevator was used for luxation. Forceps was used for extraction. The root was not fractured and it was done nicely. This is immediate implant placement. The granulation tissue within the socket needs to be thoroughly removed. The curettage needs to be done to prevent a post-op infection. I'm going to use a depth gauge to check whether the sinus has been penetrated once again. .2 twisted drill is going to be used for drilling. Sinus floor is going to be slightly penetrated. Parallel pin is going to be placed to check the path. Using 3.5 by 10 mm 1-2 taper drill, sinus floor will be slightly penetrated. Once again, depth gauge is going to be used to check whether the sinus floor has been penetrated. Final drill is diameter 4.5. I slightly penetrated the sinus floor and therefore full length drilling was not done for primary stability. If you drill full length, the hole can become too big, and I just did it so that it is slightly penetrated. Here's 3BA implant was used for implant placement. Because extraction socket is wide in this case, I did drilling. However, depending on how much force is applied, implant can move, and therefore finding the right direction is very important. The ISQ value is approximately 62. There's only engagement in the apical side, and therefore ISQ value is not very high. Cover screw is connected. On the buccal side, the gap it's approximately 3 to 4 millimeters, and therefore bone graft is going to be done. The gap is quite significant. This is the extraction socket, so allograft is going to be used for gap filling. In areas where allograft is exposed, on top of it, os guide, the collagen membrane is going to be used so that it is covered where primary closure is not possible. Collagen membrane is exposed. Hidden X suture is going to be done from mesial to distal and the other way around. This is the extraction socket, and therefore, unlike conventional suturing, collagen membrane was used for coverage and suture was done. As a result, a type of open membrane technique was used. In the past, the people used dense PTFE membrane for open membrane technique. However, in my case, if you use that, the wound did not heal nicely. And if you use collagen membrane instead and do suturing like this in an open membrane way, the collagen membrane will be resorbed in 2 to 3 weeks and soft tissue will be healed naturally. This was how surgery was complete. Thank you for watching.